So my name is Iqbal Malik, and I'm going to give you a quick run through on how to treat aortic regurgitation, where we could use a Edwards valve, a Medtronic valve, or even an Abbott valve, but they aren't bespoke technology that's ready for aortic regurgitation. They're oversized to make it happen. So this is a case that I did this year, 2025, with a Jenavalve, which is specifically designed to grab the leaflets and actually therefore make it a safe procedure for aortic regurgitation. The chap's already had, he's in his 70s, he already had mitral valve surgery and a graft. You can see the ring of the mitral valve copied out there. So we do a CT scan and align the bottom of the valve so we can get to it. And here's an angiogram showing the three cusps, the sinuses of the aortic valve outlined on fluoroscopy. So let's start by looking at the hemodynamics. So how much aortic regurgitation in there? Well, the way we assess it is looking at the pressure in the ventricle and the pressure in the aorta. The gap between the two, in this case about 30 millimeters of mercury, is what perfuses your coronary arteries, because that perfusion is in diastole. So that's not good. We should be at 50 to 60. So we put a pacing wire in, put a really fat sheath in to get the valve into position. That's quite hard to drive up to the heart. We know on CT scan that we can make it up there. And then once we've got that sheath in, we withdraw the dilator, which goes inside the sheath. You can see it's about to get to the right position. The sheath is placed in the aorta above the aortic valve. And then this valve is pushed in from the leg all the way up around the arch of the aorta and out of the sheath. That is quite hard work. It's quite a tight fit. So we don't want to go too far, because we want to open up the prongs that catch each of the sinuses before we get too close to those leaflets that we have to catch. So we unsheath, so the valve is in position, and we pull the sheath backwards and it opens up a bit like a flower, so that we get the prongs or the crowns opening up. One of those prongs needs to go into each of the sinuses that surround the aortic leaflet. So 3 leaflets, 3 sinuses. These prongs go into the sinuses, and then when we deploy the valve, the inside actually catches the leaflet, so the valve is held nice and still. So here's us opening up the crowns a bit further. So you're going to see them expand, and once they get to a decent level of expansion, there we go, we can then carefully, very carefully, push into the sinuses and orientate so that we are sure that one of those prongs is in the left sinus, one is in the non-coronary sinus, and one is in the right coronary sinus, thereby catching the leaflets exactly. So this is all done under fluoroscopy. Our patient is wide awake, a little bit of sedation if need be, and we're checking that we've caught the sinuses. So there's a non-sinus, one prong in there, and here comes the left sinus, and there's one prong in there, and the right sinus is often a bit harder to see, but we'll see it in a second that we put some dye in and triple check that the right sinus is also in position. So looks like we're ready to go, and then what we do is to make sure that we pop the valve out under rapid pacing, because we've got one shot at this. So we rapidly pace the heart at 180 or so that there's no movement, and bing, the inside has trapped the outside, so each leaflet is grabbed. So then we check the hemodynamics again, and you can see that the gap between the aortic diastolic pressure and the left ventricular end diastolic pressure is now about 60. It was 30, so a really good improvement. If you compare before and after, you may be hopefully able to see that 30 has gone to 60, and we've got a really good result. Again, with the patient awake, not feeling too much except for the pushing in the legs. And if we do a quick aortogram, we can see the valve looks in perfect position, quite close to the mitral valve, because those two valves do sit together, but not interfering with each other. And so he was back home on day 3. We kept an eye on his ECG, feeling great. And he was pretty active anyway as a cyclist, but now he can do even more, and the ventricle is going to be preserved, because a leaky valve can really upset the ventricle in the longer term, even before symptoms. Thanks for joining me.